Hi, how are you? I am Dr. Marc Taub. I am speaking to you from Memphis, Tennessee in the US. I have been asked to give a talk on autism spectrum. So I'm going to kind of break this talk up. It's going to be a fairly short and concise talk. I'm going to be talking about some of the epidemiology, some of the findings that may occur in this population, and then I'll bring you just quickly through just some basic exam techniques that you can use both for kids who have on the autism spectrum, but as well as for other kids who have other different special needs, such as just general developmental delays, as well as cerebral palsy or even Down syndrome. So autism is based on either the DSM-4 criteria or the similar ICD-10 classification, and it is an abnormal functioning must be observed in at least one of these three areas prior to the age of 3. So the first area is an impairment of social interaction. So this would be things like a decreased eye gaze, just minimal facial expression. When you look at them, they kind of have a flat affect. In terms of the decreased eye gaze, they generally won't look at you in the face. They have trouble developing peer relationships and just social emotional issues in terms of both incoming and outgoing. There's an impairment in communication, which could be a total or a delay in communication skills, or it can be one where there's a total absence. But it also can be where they're developing normally and then there's a regression. There's a lack of imaginative play. The third category is kind of the one where you might have seen where these patients or these kids will have repetitive and stereotyped behaviors. So maybe they will have a bunch of blocks and they'll put them in size order, or they'll put all of the red blocks together and the blue blocks together, maybe they'll do it by different shapes. So as I said, one of these must be observed before the age of 3. I just looked up this number again today. When I did this lecture last, it was 1 in 54 children. When I first started doing this lecture years and years and years ago, probably 10 years ago, at least, it was 1 in 150. So where did the increase come from? So is there an actual increase? I don't really truly believe there's an actual increase. I believe it's due to better detection, better and improved public and physician awareness, as well as which leads to an increase in the diagnosis of the disorder. So everybody's aware of it. And in terms of school in the US, you can get more help and more administrative help and resources if there's an actual diagnosis. So there is a documented 3 or 4 times greater propensity in males versus females. So what is the etiology? So here are just some different thoughts. We really don't know. There was this thought years and years ago, it's still out there, some of the anti-vaxxers, that the MMR vaccine was causal. And that's really because it's around the same time where a lot of children are starting to get identified as having autism. The vaccine's around 12 months, and it's starting to get diagnosed in 15 to 21-year-old months of kids, 15 to 21 months of age. There is possibly a genetic component to it. If you look at some of the studies, there's a 30% incidence in fraternal twins, 92% in identical twins, and there's a risk of recurrence between family members of 2 to 7%. Hold on one second. And the relative risk of is 50 to 200 times greater in families than it is in the general population. There are a higher number of documented comorbidities, Fragile X syndrome anywhere between 3 and 25%, epilepsy 7 to 14, tuberous sclerosis, Down syndrome, CP, are all higher in these populations. In terms of ocular manifestations, we're looking at refractive error and visual acuity. It's highly variable in this population. There is a higher percentage of ocular motor deficiencies. The hard part is getting the patients to fixate and attend during the test. In strabismus, mostly intermittent. Most of the time it's going to be an exotropia versus an esotropia. And depending on the study, anywhere from 21 to 84%, so pretty widely varied. In terms of behaviors, and if you've ever worked with or been around a kid with autism, these are some things that may have been apparent to you. There'll be gaze avoidance, as I said, they don't want to look at your face. There's eye pressing, there's hand flicking, anything to try to get a visual stimulation. There is a poor visual awareness of the surroundings. So they're going to be generally very central, which goes along with the fascination of spinning lights and shadows and bright objects. So they're going to be very central and not be aware of their periphery. So what are some of the things that we're going to be doing to test these kids? This study was done by Stacy Coulter, who was one of my mentors down at Nova Southeastern University. She looked at 61 children, 31 with on the spectrum, and she actually did exams on them. She created a social story, which essentially is kind of a picture book, which the kids can look at and the parents can go through to kind of ease the tension and avoid those social meltdowns. And that story goes from the beginning of the exam to even, you're going to walk in the door and this is the person that's going to greet you, to, the doctor is going to put these drops in your eyes and they may tickle a little bit, just so they're aware of what's going to be going on. The testing they did, you can see right there, they pretty much did a full exam, including IOP, anterior post-seg, and results. They found that testability was very high on most tests. They broke it down into two groups, the ASD kids. So they broke out the nonverbal kids, and you can see that there was a little bit of a difference, but not a tremendous amount. The lowest testability was, as you can imagine, the intraocular pressure. And there's a big difference between the 70% in the total group, but then 30% when they broke out the nonverbal kids. So as you can see, in just traditional testing, that they were very successful in getting the testing done between 90% of the time on most of the kids, but then 75 to 100% in the nonverbal kids. So in your examination, as I said, the history should be done really before, not the history, but the kind of the social story. With the history, I like to use intake forms and questionnaires, sending that ahead of time so that you're maximizing the amount of time that you have with them in the office. Getting any previous history is quite important, whether it be from the occupational therapist, physical therapist, neurodevelopmental pediatrician, whoever they're working with, gathering that information and even potentially having a conversation with them beforehand about the behaviors that they're seeing and they'd like you to try to kind of decipher. Obviously, as in any medical history, ocular systemic medications are very important, as well as side effects. Many medications that they're taking can cause changes in vision, especially accommodation. So what are some of the tests? So this is called the Color Vision Made Easy. Color Vision Made Easy is great for little kids, as well as patients who don't know their numbers. Essentially, you're asking them, instead of, you could ask them what shapes they see, but if they don't know the shapes, you can have them use a pencil eraser or a Q-tip, something like that. Don't want them to use their fingers because that'll leave oil on it, to just trace the shapes. The wool yarn test is kind of not necessarily an official test, but putting down strips of different colored yarns and having them match it up. It's just, it gives you an idea of what they can see color-wise. For the stereopsis, the one that I like, I don't necessarily love the Lang stereo test. That's the one, that's the second, the test, the two pictures on the right of your screen. I personally find the test very challenging and the pictures are really hard to discern. The one I like, if we're going to go for something, of course you can do a traditional stereo test, but if the patient is has sensory issues and they don't like putting on the glasses, these are the ones that you would use. For the random E test, you can see there on the picture, there are 3 plates. The one in the middle is the test plate, the demo plate, so you can see what you're supposed to be seeing. And then one plate has the E and one does not. So they essentially have to pick out which one does. So it's a forced choice test. For visual field testing, this is really just looking for gross peripheral defects in areas of constriction or neglect. So you can see that one of my students, these are both my students, were my students years ago. So you're standing behind the patient and imagine I'm the patient and you're bringing in this visual target, not auditory. Make sure it's not auditory, because if they do look over, you don't know whether they're looking over or they're hearing it and they're kind of directing their gaze. So as soon as they look over, you know that that's the extent of their visual field. And you're just looking for gross constriction. So you're coming from kind of each different quadrant. For accommodative assessment, I generally try to stick to the MEM. That is a great method for just an objective measure. I've learned over the years to just in general do more objective testing for just every child. So certainly on the ASD kids, I'm going to do that more and more. I remember you're doing this at the patient's Harmon distance. So that's the distance from their knuckle to their elbow. So you're getting very close to the patient. And this is performed with targets that are based on the patient's age and educational level. So you can see in the bottom left, we've got pictures with cards with pictures on them, but then we also have cards with words on them. And the expected value for this is just a little bit hyperopic. So you remember have to do each eye individually. Both eyes are open at the same time, but you're scoping each eye individually and each axis individually. For EOM's assessment, so this is really fun. So you want to, you can have a toy that has kind of a spinning toy to it. You can have ones that have different sounds, and you're really just looking for gross EOM movement. If the patient is constantly moving their head, you may have to apply just a little bit of pressure and have them kind of look all around. For pursuits and saccadic testing, you have the kind of the SCCO versus the NSUCO method. Essentially, one is sitting and one is standing. If the patient is really low on the ASD spectrum, you may actually have to have them lay down on their back to get rid of gravity and to make it, because you really just want to assess the eye movements. For binocular posture, direct observation, obviously, if you see one eye out or one eye in, do you really need to do the Bruckner? No, not really. But sometimes those angles are very subtle, and if the patient's moving around a lot, sometimes can be very hard to see. So obviously I use my direct ophthalmoscope, and I'm shining this wide, bright light into both eyes at the same time. And if one has a brighter reflex, it's either more likely to be strabismic or amblyopic. Unfortunately, it can also indicate things like Coates disease or retinoblastoma, but those are on the rare side. The Hirschberg test, for a lot of kids on the spectrum, getting something close to their face can be quite challenging. So this is pretty easy in terms of you're just using a pen light or a transilluminator, and you're just shining it in both eyes at the same time. You can see that in the picture on the left. Both images, reflexes are quite aligned, but then in the picture on the right, you can see that the right eye is turned in. So if the right eye is turned in, you can see that the reflex is temporarily deviated. And it'll be the opposite for the if the eye is turned out, it will be nasally deviated. Based on the literature, we found that about a 1 millimeter difference between the reflexes equals about 22 prism diopters. So this gives you a gross estimate of the magnitude of the eye turn. You also have the Krimsky test, which is using the Hirschberg reflexes and aligning them using a prism bar. You've got the cover test, of course, and you can do the cover test with either an opaque or a kind of a translucent occluder, a frosted occluder. I like the frosted occluder because you get to see what the eyes are doing behind the panel. NPC is a very quick test. Again, using a little puppet, a spinning light, just bringing it real close. You're not looking for, is it 5 centimeters or 6 centimeters? You're looking for just an idea of gross convergence. For visual acuity assessment, I love the Leah symbols. Developmentally for ages 2 to 5, but that kind of goes out the window when you have a patient who's on the spectrum. You can use this on any age patient that you'd like. I actually use Leah symbols when I go to the rehab centers and work with stroke patients. Sometimes they forget their letters, so kind of bringing them back down the developmental pathway using the shapes can be quite beneficial. This test has 4 different shapes: a circle, a square, a house, and an apple. The cool thing about this is that when you're getting to that kind of visual acuity level, all of them blur to look like circles. So if the patient calls out circle, circle, square, circle, then you're kind of getting and hitting that kind of that level at which acuity is starting to fade. You also have the Tumbling E test. The Tumbling E is, I don't have the picture, but it's essentially a chart with different E's in different directions. The patient has to tell you the orientation of the, I call them the legs of the letter E, either up, down, left, or right. The hard part about this is for kids who have laterality directionality issues in which left and right is trouble. So not my favorite test, but one that you can use. You also have the Teller Acuity cards. Teller Acuity cards, again, we use for patients really of any age. And I'll even use them for 3 or 4-year-olds if they don't know their shapes. It's a force preferential looking model. So you can see in the picture on the left that there's a grading pattern on one side of the card and the other side is gray. The person is looking through the little pinhole in the middle and looking for where the eyes move towards. If the patient can see and is visually attending, they're going to typically go and look at the side with the grading pattern on it. We also have the Cardiff cards. The Cardiff cards is a vertically oriented force choice looking test. It's based off of not grading, but vanishing optotypes, which you can see in the 2 pictures there. Obviously, the one on the left is going to be harder for the patient to see, and hence a lower visual acuity. Here we've got shapes that and pictures that are very familiar to the patients. The house, the car, of course, we've got the duck here. We also have the OKN drum. The OKN, actually, you can use the drum, you can use an OKN flag. I've even seen OKN on a computer or a tablet. You always have, if you really get desperate, electrodiagnostic testing. In the US, many of the colleges of optometry have this testing, as well as many offices, as the price of the equipment and portability of it has gotten better. For refractive error, you've got your static retinoscopy. I personally rarely put patients behind the phoropter at all at this point. So I use either the lens racks or I will simply use my loose lenses, which I actually find easier and more reliable. You always have the Mahindra retinoscopy, which is certainly useful. It's not one that I do very often. I will just use my loose lenses and kind of take up my working distance as needed. For measuring pressure, this is a portable non-contact tonometer, an NCT. This would hang on the wall, and this is kind of the puff of air. You do want to warn the patients, but I will tell you, sometimes if you warn them too much, then they get a little skittish. I will say that sometimes I've gotten one eye, and then getting them back in there for the other eye is virtually impossible. We have, of course, Goldman tonometry. We have to use the anesthesia, wouldn't recommend it. We also have the eye care tonometer. This, of course, does not require drops. A light probe, kind of even thinner than a needle, kind of pops out and touches that eye. I've had it done to me, and I'm on the skittish side, and if I can tolerate it, almost anybody can tolerate it. And of course, when all else fails, looking for digital estimation using just a finger tension, and that'll give you just a general idea of, is it hard, soft, or kind of somewhere in the middle? You need to be worried. For your anterior segment evaluation, I tend to use my 20D lens plus just a 10 light. Really, the most important thing is you're looking just to make sure that you're not going to close the angles. Very, 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 very rarely is there very much going on anterior segment wise. This is a product called the Bluminator, and it uses kind of you can either get it in blue light or white light, and it's a 7 times magnification. As I said, I just use my transilluminator and my lens. For your posterior seg evaluation, you just have to be very creative and really meet the patient where they are. You may have to have the patient laying on the floor. Often, if they're a younger child, I'll have them sitting in their parent's lap. It may just be in just a regular chair. It may not be in the exam chair. I've crawled on the floor. I've made noise. More recently, I've taken to finding out what kind of video they like and playing it on my phone and having another person stand behind me to get their gaze. I also will use a lot less light than other people and may even have to go to my red-free or my green filter to promote cooperation. In very rare cases, sedation may be required, and if that's the case, you need to work with an ophthalmologist to get that done. But overall, I think you could be successful and wish you the best of luck.